Capsular contracture release, e.g., sever type procedure. Capsular contracture release is not commonly performed unless the shoulder is fixed in marked internal rotation and adduction. In this position, the arm is unable to move away from the body. The physician makes an incision at the front of the shoulder where the deltoid meets the pectoral muscle. The subscapularis tendon is removed from the glenoid rim. The anterior capsule is left intact. The pectoralis major tendon is severed from its attachment on the humerus. The skin incision is closed and a soft dressing is applied. The arm is positioned in abduction, arm elevated out to the side of the body. Release, tarsal tunnel, posterior tibial nerve decompression. The physician releases the tarsal tunnel, decompressing the posterior tibial nerve. The tarsal tunnel is located on the inside of the ankle. A curved incision is made along the inner ankle, behind the medial malleolus. Dissection exposes the flexor retinaculum. The retinaculum is released along the tunnel. The posterior tibial nerve is identified by blunt dissection and traced as it courses down through the tarsal tunnel. Three branches of the posterior tibial nerve are also traced at the point. Once the posterior tibial nerve and its terminal branches are released, the nerve is inspected to see if any other constrictions are present. The incision is closed layers without closing the retinaculum. Release, intrinsic muscles of hand, each muscle. The physician releases the intrinsic muscles of the hand to restore intrinsic function. The physician incises the overlying skin and dissects to the contracted muscle. The intrinsic muscle is incised to release contracture. The incision is sutured in layers. When reporting this procedure, indicate which intrinsic muscle was released, interossei or lumbricals. If microsurgery is used, report using modifier -20 or 09920. Report each muscle separately. Release or recession, hamstring, proximal. The hamstring tendon is a fibrous connective tissue extension that attaches the hamstrings muscles to bone. The hamstrings include the semitendinous, semimembranous, and biceps femoris. They flex and extend the thigh. The hamstring's origins are in the ischium or femur and the insertions are in the tibia and fibula. The physician makes an incision overlying the hamstring origin. Muscle and fascia is exposed. The physician makes multiple cuts in muscle fascia. The incision is repaired in layers. Lateral retinacular release open. The physician performs an open lateral retinacular release. Lateral retinacular release is done when too much lateral tension on the patella from tightness of the lateral retinaculum causes patellar misalignment, not allowing correct movement. This can be associated with articular cartilage lesions and idiopathic chondromalacia. The physician makes an incision to access the lateral patellofemoral and the lateral patellotibial ligaments. These tight lateral ligaments that are holding the patella out of alignment, are released, detaching the patella from the soft tissue structures, including the lateral retinaculum, muscle fibers, and joint capsule. Release of thenar muscle, e.g., thumb contracture. The physician incises the thenar muscle to release, for example, thumb contracture. The physician incises the overlying skin and dissects to the thenar muscle. The scarred muscle tissue is incised to release contracture. The incision is sutured in layers. Release of encircling material, posterior segment. The physician inserts an ocular speculum. To release the tension in a previously placed scleral buckle, the physician makes an incision in the conjunctiva and sclera, adjusts the buckle, and repairs the surgical wound with sutures. Release of extensive scar tissue without detaching extraocular muscle. During the performance of separately reported horizontal muscle surgery, scar tissue from a vertical muscle is excised. Or, during the performance of separately reported vertical muscle surgery, horizontal muscle scar tissue is excised. The scar tissue of the extraocular muscle is isolated, and the physician uses a scalpel to dissect the scars and fibrotic tissue from the muscle affecting the muscle itself. The surgical wound is closed with sutures. Coracoacromial ligament release, with or without acromioplasty. The physician performs a coracoacromial ligament release, with or without acromioplasty. The patient is positioned on the side with the affected side up. The physician makes an incision centered over the acromioclavicular joint. The soft tissues are reflected and the ligament between the coracoid and the acromion is released. The physician may perform an acromioplasty where the underside of the acromion is reduced to allow more room for the rotator cuff tendons. Acromioplasty involves the division of the acromioclavicular ligament followed by the use of a burr to cut away the undersurface of the acromion. During acromionectomy, the distal portion of the acromion is removed. Following completion, the joint is irrigated and the incisions are closed with sutures or stri strips. Acromioplasty involves the division of the acromioclavicular ligament followed by the use of a burr to cut away the undersurface of the acromion. During acromionectomy, the distal portion of the acromion is removed. Following completion, the joint is irrigated and the incisions are closed with sutures or stri strips. Reduction of craniomegalic skull, e.g., treated hydrocephalus, not requiring bone grafts or cranioplasty. Requiring craniotomy and reconstruction with or without bone graft, includes obtaining grafts. The physician reduces an enlarged skull, e.g., secondary to hydrocephalus. The physician incises and retracts the scalp to expose the cranium. In 62115, the skull is cut and the bone is reshaped. In 62116, bone flaps are raised. After reshaping, the bony fragments are replaced and stabilized.